I think we'll start. Okay, so today is a very interesting topic. We have a discussion on case of a keratoconus. Maybe it's a keratoconus or not. We'll come to know, and it will be presented by Dr. Rushali, who's a third-year resident from Nair, and Dr. Amaya will be giving inputs about this case. And I think everyone should be ready with all their questions because he's one of the best person to answer all your questions. I'll just give you a brief introduction about Dr. Amaya. So Dr. Amaya has done his DNB and his fellowship from Shankara Eye Hospital, Coimbatore, and he takes special interest in cornea. And actually, his first name is Cornea Guy, and secondly, he's known as Amaya. So if you'll search, you'll have to search for Cornea Guy, and he has a very good YouTube channel, which with some beautiful surgeries and even some some memes video as well. So whenever you get time, you should sign in, and we are very thankful for to Dr. Amaya to spare time to help us with this case. So I think we'll go to Dr. Rushali, and we'll just go ahead.
Good evening, everyone. Good evening, everyone. I'll be presenting a case today of a 23-year-old male who is a student who came with a chief complaint of painless, gradual, progressive diminution of vision in his left eye and a high number in left eye. Ocular history, patient was prescribed glasses.
I think little voice is little breaking. How's it for others?
It's fine.
Should I continue, sir?
Yeah, continue.
Ocular history, a patient was prescribed glasses, but he did not use it. There is no.
Okay, now the network is gone. Can't hear anything.
Of any previous surgery, personal history, allergies, family history is not significant. Bilateral symmetrical with a central corneal reflex. Vision in right eye is 6 and keratometric readings are normal. While in left eye, the vision is finger counting 1 meter. Autorefractometry showed a high cylinder, and on retinoscopy, a scissoring reflex was appreciated. The keratometry findings were the K1 was at 50.56 at 138 degrees, and K2 was 56.19 at 48 degrees. On slit lamp examination, the right eye findings were within normal limit, while in left eye, the cornea showed anterior bowing with central thinning, and the anterior chamber was deep. Rest findings of anterior segment were within normal limit. The posterior segment examination was also within normal limit with 0.4 CDR with healthy optic disc and periphery normal periphery. On slit lamp examination, we can see there is anterior bowing of the cornea, and on topography we can see topography was done for the left eye, where we can see the central corneal thinning was appreciated. So my diagnosis is right eye within normal limit, while left eye is keratoconus with central corneal thinning. That's it, sir.
Okay. Right. Let's just go back to the first slide, the history. Okay. Now, you say gradual progressive diminution of vision in the left eye and high number in the left eye. But what's the history of that number? Do you have any retrospective history?
No, sir, I don't have any history.
Did you ask him whether his number has changed or what his number was earlier?
No, sir.
Is it relevant?
Yeah. Yes, sir. Yes, sir. It is relevant because keratoconus is a progressive. It is a progressive disease. So the patient will give history of changing the number, changing the spectacle prescription, frequent change in the spectacle prescription.
keratoconus is a progressive disease. That is correct. However,
Yes.
how is the
Yes.
progression relevant to you? Does it alter your treatment decisions?
Yes, sir. It will alter the
How?
treatment decision. Uh, Sir, in a rapidly progressive disease, we can go for a corneal collagen cross-linking,
Okay.
or if it is slowly progressing, we can give a trial of contact lenses or rigid permeable lenses.
Slowly and rapidly, like, is there any criteria for this, or is this like, or is there something else? So it's not like that. Any kind of progressive disease, you're
Yeah.
supposed to treat with
Okay.
corneal collagen cross-linking if it is possible.
Okay, sir.
And if there is no progression, in that case, you should not treat with corneal collagen cross-linking, because cross-linking has its own side effects and its problems. So do not treat
Yes.
keratoconus. It's not like the moment you diagnose keratoconus, you're supposed to cross-link. You should have evidence of progression, and there are certain criteria for that. You can look that up. Okay. There are certain criteria for progression of keratoconus. Unless those criteria are documented, you're not justified in doing a corneal collagen cross-linking. If you do it, and if something goes wrong, you can be held liable for that. Okay. Now that's the first thing. Now it says progressive diminution of vision in the left eye, but nothing in the right eye, right?
Yeah. No, sir.
Okay. Go to the next slide. Prescribed glasses, but did not use it. Okay. No history of previous. What else? What else do you think could be relevant history here for keratoconus specifically? What should you ask? What are the known risk factors for keratoconus?
Sir, usually any collagen vascular disease, collagen diseases,
Such as?
Ehlers-Danlos syndrome.
Okay. What else? Marfan's, Downs, Lieber's.
Marfan's, yeah, Down syndrome.
Yeah, so you should, you can mention that somewhere else, maybe
Yeah.
not here, but somewhere else in your history, that there were no morphological abnormalities, that his height was normal, he did not look like a Marfan's, and so on. Okay.
Okay, sir.
Then
Okay, sir.
what else is relevant? What else can predispose to, why in Lieber's congenital, what causes the keratoconus, and in Downs?
So patient can give history of frequent rubbing of eyes
Exactly.
due
So
to
this is
any
one
allergic
relevant history which you didn't
conditions.
take. Correct.
Yes.
It need not be because of allergy. Like in Lieber's, it's not because of allergy,
Yeah.
but it's just poking of the eyes or rubbing of the eyes. Okay. Even in Downs,
Yes.
it may not always be associated with an allergy. So that is one thing you should be asking for. This is a specific history which you should mention relevantly.
Yes.
Like, okay, there is no history of eye rubbing as given by the patient or by their parents. Okay.
Okay.
Systemic illness. Now, just out of curiosity, do you know any associations of any things systemically which could be related to keratoconus in any way? Any specific serum test you want to do? So anyway, I'll tell you. Recently, there are some papers on how serum vitamin D3 levels might be associated with keratoconus. So that, and you should also be doing serum IgE, which is a marker for allergy.
Allergy, yes.
Okay. Then family history. You've written not significant. I don't think that's good enough. You should describe in more detail. What did you ask?
Sir, any similar history in the family, because there is a higher risk if any first degree relative is.
How is he going to know? The first time you're seeing this patient, the first time you're telling this patient is that, and you're telling them this patient has keratoconus, right? The patient doesn't know that he has keratoconus. First time he's hearing this word in his life. So how is he going to tell you whether somebody else has it? Never heard of it before. What will you ask? Are you going to ask this patient, does anyone else in your family have keratoconus? Obviously, he's going to say no. He doesn't know. What will you ask?
Any history of any corneal surgeries?
No. Okay, that's like very late. But you want to catch it early, right? You want to save his siblings from getting advanced keratoconus. Correct. You should be asking if any of your siblings have glasses, and you should be telling this patient to call up that sibling or that cousin or whoever, and to ask them whether their glasses have changed, and if so, or just prophylactically get everybody's topography done, because it does run in families. It doesn't have a very proper or very well defined genetic transmission, but it is definitely known to occur in families. Okay.
Okay, sir.
So you have to ask a very specific question. You have to, and in your history, when you're writing it, you have to write that the patient does not gives a history of no other relative in the adolescent age group having glasses which are changing frequently. At least the patient is not aware of this. You must mention this specifically like
Okay,
this.
sir. Okay, sir.
Okay. Okay. Next.
Okay, sir.
Now this doesn't go very well with me. Okay,
Okay.
right eye being completely normal, which it does appear to be, and left eye
Yes.
being high cylinder scissoring reflex seen, etc.
Yes.
Okay, now just for since you guys are going to give exams and all soon, why don't you just tell me all the named signs of keratoconus? When I say name means
Uh,
somebody's name is
yes.
scientist name, yeah.
Yes, sir. Munson's sign, sir,
Okay,
which is inferior deviation of the lower eyelid on the down gaze.
okay.
Rizzotti sign is seen on torchlight examination, but is not specific sign. When we throw a torchlight from the temporal side, the cone shaped light is seen on the nasal limbus, cone
Okay.
shaped ray of light. And Flesher's ring is seen commonly, which is an iron deposition seen on cobalt blue filter. Meta seen with cobalt blue filter. Both stria are the vertical parallel lines seen in the stroma, and
Yes.
they disappear when pressure is applied on external pressure.
Okay.
And sometimes scarring can be seen, which can be reticular, nummular, or deep stromal scarring.
Okay. What else? Charlot, Charleaux. Have you heard of this? Hello?
No, sir, no, sir.
Yeah,
No, sir, I'm
Charlot's,
not wrong.
it's called Charlot's oil droplet reflex. When you do a
Yeah,
retinoscope,
oil droplet. Okay.
Charlot,
Yes.
Charleaux. Okay.
Okay.
Right. So all that is, you probably saw all of this. Okay. But however,
Yes, sir.
another very relevant history that you forgot to ask, or at least you have not mentioned it, but it is very relevant. Can you tell me one more thing? Can someone else mention this? It's very important, and she has just missed it outright. History.
So history of any contact lens
Yes, good. That is also important.
previously.
And
Dr. Vaidhi, anyone from the audience? Dr. Mohammed?
some surgery she should have asked about. She's asked her family members about surgery.
Any
LASIK
yeah,
surgery.
Yeah,
any myopic
LASIK.
surgery for any refractive surgery.
refractive surgery, exactly. Corneal refractive surgery is a very important history, because if the other eye is 6/6 with a fairly normal looking keratometry, for all you know, it could be a post-LASIK eye, right?
Yes, sir. Yes.
And the other eye might have gotten into ectasia. So we don't really know unless you ask and unless you check the topography.
Yes.
Okay. So you should mention this again in the history. The history should have
Yes,
this
okay.
negative history saying that no corneal refractive surgery was done. Corneal, you have to say corneal. It doesn't matter if the
Yes.
patient has gone for a phakic IOL. Okay.
Yes.
Right. So scissoring is seen and this keratometry is seen. Okay, go to the next page. Anterior bowing with central thinning. Right now, do you really think this matches with keratoconus? Do you think it's possible that one eye is so severely affected and the other eye is not at all affected? According to you, it's okay even if you're wrong.
So no, because keratoconus is really bilateral.
Usually it's bilateral. At
Yeah.
least if with an advanced keratoconus in the left eye, you would expect at least a formed keratoconus or some early changes in the right eye. So
Yes.
this is not really going well with us. So what else could it be? What are your differentials? Tell me all the ecstatic
Sir,
conditions of the eye.
yes. So pellucid marginal degeneration.
Do you think this fits?
No,
What are the
sir, because
characteristics
it
of
is
pellucid and
usually
how is it different from keratoconus?
Sir, in
uh,
pellucid inferior
in
corneal thin.
Yeah, so there is inferior corneal. This is Irene Rose speaking. So Irene,
Yes.
pellucid marginal degeneration, it has inferior thinning. Is there any relationship
inferior.
between where the thinning is and where the apex is?
Sir, I don't know.
Yeah.
Sir,
So
in keratoconus, the thinning will be associated with steepening, whereas in pellucid marginal degeneration, the steepening will be superior and the thinning will be relatively inferior.
Yes, absolutely right. So, Kuntavai, correct. Okay. That is the correct thing. Next. So, PMD you said, keratoconus you said, what else? Differentials. Also,
marginal
another, sorry, Kuntavai,
degeneration.
pellucid marginal degeneration is in usually in which age group and keratoconus is in which age group?
Sir, keratoconus, it is in puberty adolescent age group, and
Yes.
pellucid margin is around 20 to 40 years.
Very good. Absolutely right. Good. Next. What other ecstatic condition is there?
Terrian marginal
Terians. Okay. Terians. Then what else?
degeneration.
Next.
Sir, keratoglobus.
Keratoglobus. How is
So it can
keratoglobus?
be
Sorry. Whoever said keratoglobus, just describe it once.
Sir, globular thinning of the cornea.
Okay.
Yes, sir.
May I, sir? Try?
Yeah, go on.
In keratoglobus, it presents usually at birth, and when there is thinning which is involving more than 75% of the cornea with the generalized thinning, we call it keratoglobus.
Good. That's correct. Okay. Right. So all of your answers are correct, and pretty much for the exam and post-LASIK ectasia or post-refractive ectasia is another important thing which you can mention in this. Now, other than that, I'll just tell you for this particular case what my differential is, and it's a rather uncommon thing. Even I have not seen many cases of this. I've seen about only 5 or 6 cases. But what I believe to be the diagnosis is something totally different. It is birth trauma. Okay. Many times birth trauma presents like this. The birth trauma will show a tear in the desmoid membrane. You will be able to see this spindle shaped tear at the endothelial level, like just above the endothelium, just anterior to the endothelium. So next time you call this patient, okay, I want you to carefully look at the endothelium and see whether you can see a spindle shaped cut. Okay, and right above that spindle shaped cut, you will find this localized thinning of the cornea. So tell me, since you have seen this patient on, you have seen the patient on a slit lamp, right?
Yes, sir.
Yeah, Brushali. Okay. So if you remember, do you remember whether the thinning was very localized to just a central area and whether the rest of the peripheral cornea was quite normal looking?
Yes, sir.
Yeah, so most likely this is that kind of a thing, which is why in this case you should also take a birth history of a difficult birth or a forceps delivery. Many times forceps deliveries cause tears to the desmoid membrane and the Duas layer inadvertently, and that leads to something like a hydrops, and then later on it eventually ends up with thinning, which further becomes ectatic. Okay, now this is why is this very relevant? Again, this is where your past history comes in, where if there is a change in spectacles, this shows that it's a progressive ectatic condition. All the previous conditions that you told me just before this, all of you told all the conditions, they are all progressive ectatic conditions, whereas this particular one is not progressive. Okay, and it is probably there since at least early childhood. So if this patient has had specs for the other eye, or at least for in this case the patient has never had specs, and you say that the patient was prescribed specs but did not wear them, what do you think? Why did he not wear them? He's likely amblyopic.
Yes.
Because he's had this from probably from birth. Okay, so whatever you do is not really going to help this patient. So in this particular case, I don't think this is keratoconus, and I think this is birth trauma. But you'll have to really check. Like I can't just make this claim. Oh yeah, somebody over here, Muhammad Fahad has read. Yeah, somebody has exactly mentioned this. Sir, if there is history of birth trauma up to this age, the affected eye might have went into amblyopia since visual acuity is unequal. Please explain. So I think Mohammed, I have explained the thing to you, right? Okay. Right. So that explains the visual acuity also. Can you just show me the visual acuity? What was it? Vrushali? Vrushali, you there? Can you just go to the visual acuity slide?
Yes.
Okay. This is keratometry. Visual acuity. Finger counting 1 meter with what? With nothing, right?
Yes, unaided vision.
And best corrected? You could not correct.
So he was not.
Uh,
Yes.
do you have access to contact lenses over there? Like, can you do a over refraction with contact lenses?
Oh, okay, sir. We'll do.
Yeah, I mean, that's how you would really know the visual potential of this patient, right? You would put an RGP or preferably a scleral lens on this
Yes.
patient and neutralize his irregular astigmatism, and then you find, and then you do over refraction on that. Then you'll know what is the actual visual acuity and what is the, how much amblyopia this patient has. Okay, like what you have done right now is inadequate for us to really judge whether or not we should intervene, because right now if it's finger counting 1 meter and if it's dense amblyopia, then there's no point in doing anything. But with a scleral contact lens, if this patient's visual acuity improves to say whatever 612, 6.9, then you would definitely want to do something for this patient, right?
Dr. Ramaya, can you just explain a little more about this over refraction? Like,
yes,
how
yes,
do we
I
go
think,
about it?
yeah, I think people might not have understood. You're right. Okay, so I'll just explain now. In general, in keratoconus and in other ectatic conditions of the cornea, the cornea becomes irregularly shaped. Like the keratoconus, the cone is an irregular structure. So spectacles cannot fully correct this, because spectacles require a very symmetric shape of cornea in order to refract properly. So simple astigmatism is okay, myopia is okay, hypermetropia is okay. But if the cornea is shaped very oddly, whatever specs you put in front of this patient's eye, the rays of light will not get focused to a point. There will not be a point focus. There is nothing you can do about this. Because of this, the best corrected visual acuity in keratoconus patients with spectacles, it cannot be perfect. However, what we can do to neutralize this irregularity of the cornea is to place a contact lens on top of the cornea. But this contact lens cannot be a soft contact lens. If you place a soft contact lens on top of the cornea, the soft contact lens will also take up the shape of the irregular cornea. So you have to put a lens which will maintain its symmetric spherical shape on the anterior surface, place that on the cornea, and then do a refraction. So in the olden days, we used to mostly do this with rigid gas permeable lenses. They were little rigid lenses which used to sit on top of the cornea. That will regularize the shape. The anterior surface of that lens obviously will be perfectly spherical. And then an optometrist does a refraction. So the total refraction, this is called an over refraction, as in a refraction over a contact lens. So after the contact lens is put, then a refraction with spectacles is done, where the anterior surface of the cornea is now spherical because of the contact lens sitting on top of it. Then the refraction is done. Then a correction is given for the vertex distance, because the spectacle prescription, I mean the spectacle calculation is being done at say 12 millimeters in front of the cornea, but the contact lens, which has its own power, is sitting exactly at the cornea. So a vertex correction is given, and the two, that is the spectacles power which we got and the contact lens which we had kept on the eye, they are added up, and the net thing is what the actual patient's actual refractive error is. So when a new contact lens is then given to this patient, it will be the sum of that contact lens plus whatever was the spectacle prescription which we got with over refraction. And this will give us the true visual acuity of this patient. That is the best corrected visual acuity with contact lenses. This can be better done with scleral contact lenses. Now, in the olden days, rigid gas permeable lenses were there. They were much smaller. They're only about 8 millimeters or so large. They sit on top of the cornea. They rub the cornea. And in very ectatic conditions, like very advanced keratoconus, because the cornea is very steep, but the base curve of the contact lens is not that steep, the lens tends to rock. It is not stable, and the lens gets pushed out of the eye because the edge gets lifted up. So rigid gas permeable lenses, they are uncomfortable and they don't sit well on highly advanced keratoconus cones. So then Mr. Rose, he invented what you all know as the Rose K lens, which is the Rose keratoconus lens. It is basically a rigid gas permeable lens, but in the middle of that lens, there is like a khadda, there is a depression inside which the cone sits. So because the cone sits inside that khadda, the lens doesn't rock as much, it's more stable. Obviously, I'm oversimplifying this. There are various designs to a Rose K lens, and different cones require different lenses. But these are all gas permeable lenses which touch the actual cornea. Subsequently, in Boston, something known as Prose lenses were invented. They are basically prosthetic devices, but they are scleral lenses. That means they don't touch the cornea at all. They are much bigger. They are almost 22 millimeters in size, which is quite big. And their edges do not touch the cornea. Their edges actually rest on the sclera. And there is a gap between the cornea and the inner surface of the contact lens. In Indian eyes, it's very difficult and it's a little tedious to fit these big contact lenses. Also, they're really expensive. They cost almost 1.5 lakh rupees per eye. So for the most part in India, mostly we practice mini scleral lenses, which are basically a smaller version of this, where they are 16 to 18 millimeters in size. They also do not touch the cornea and they land on the sclera. So this is kind of an overview of the specialty lenses, contact lenses that we use to diagnose as well as treat the refractive error in keratoconus patients. I hope that's clear. Yes, Prushali?
Yes, sir.
Okay. Go on, next. Okay. IDEO, I think, is for Anuj.
Idea is for everyone.
Yeah, it's for everyone. Okay, good. Next. Yeah, so if you see this picture also, this is the actual picture of the patient.
Yes, sir.
Yeah, if you see it, it does look like what I'm saying, just the central part is appearing very thin and the rest of it is pretty normal looking. So I do suspect this bird trauma, but I can't say until I actually see the patient and I see the endothelium. But yeah, I mean, that's a differential for us. Keratoconus is highly unlikely, to be honest. Okay, but still it's fine. Next.
Okay. Okay.
Okay.
The topography.
Now, just for your exam, I'm going to be asking, let's hold some, let's take someone else. Who's a volunteer? Who's going to describe this topography to me? And first of all, is it a topography?
Dr. Asma, Dr. Aparna, Dr. Urvi, Rutuja, Dr. Rutuja, anyone please volunteer?
Yeah. It's okay. You can be wrong. Who cares? It's fine. I'm not, going to cut marks. Chalo, I'll pick a name.
You can just change your name and just volunteer.
Asma Parveen will answer this. Come on.
I think everyone is out for dinner.
Out for dinner. Urvi? Is Urvi here? Okay, nobody wants to answer. Right. In
Dr. Mohammed from Pakistan? Maybe international residents are more interested.
Yeah, Mohammed, possible? Can you describe the topo? Can you just tell me what all maps are there, what all you're supposed to look at? I'm just going to teach you basic topography and how to look at it. That's all. I am not here to ask you very deep questions on keratoconus.
Hello, sir.
Hi, Mohammed. Yeah, tell me.
Sir, exactly. I don't know how to describe, but I can tell you actually something which I know. So basically, we have to describe about the anterior curvature map of the cornea, the posterior curvature maps, and the steepest and flattest meridians. And you can also comment on the anterior chamber depth. And basically, we have to look for K1, K2 readings, and where is the cornea steepest and flattest.
Okay. So, Mohammed, let me just get back. Now, before you even look at anything on the map, what should be the first thing you look at? Like, for example, when you're doing an A scan, you look at SD, right? Standard deviation, and you make sure that it's under 4, 0.04. So, what is the corresponding thing in a topography map?
Sir, also we can also look for the K value should be less than, it should be in between 0 to 1, I think.
No. So what I'm asking you is actually the quality indices, how well the scan has been taken. Because if the patient was moving or the patient closed their eyes, blinked their eyes, then the scan is totally unreliable. You'll get what looks like keratoconus, but actually it's nothing. It's just bad tear film, or it's the patient moved when the scan was being taken. So there
Yes,
is like in a pentacam, there is something known as QS, which is the quality index, how
quality
good the scan
specification
is.
will be.
Yeah, quality specification, correct. So for every machine, there is something like that which tells you what is the quality of the scan. That is the first thing your eyes should go to before you start interpreting it. Okay.
Right.
So
Yes.
once you realize that the quality is good, you tell me what are these 4 maps. First, you said elevation anterior, elevation posterior. What else is there?
So anterior elevation maps and posterior maps of the cornea.
Okay. And what else? What are the other 2? There are 4, no?
Yes, sir, there are 4.
What are the other 2?
And yes, sir. One is telling you the thickness.
Correct. Pachymetry map. That's the thickness map. Then,
yes, central corneal thickness.
yes. What else?
And the fourth one, sir, the steepest and the flattest meridians.
Yeah, it's called the keratometry map.
Keratometry map. Yes.
Okay, that's good. So these are the 4 basic maps. They're there in all tomography machines. This is actually not a topography. This is a tomography, because we have anterior as well as posterior elevation. There are some other machines which use Placido disc, and they are only for anterior, only for keratometry. They can only measure keratometry. They cannot measure pachy. They cannot measure anterior elevation or posterior elevation. Now I'm just saying anterior elevation, posterior elevation. What do I mean by that? Elevation from what? What is it being compared to?
To the best fit. Yes.
Compared from the age-related normal age groups of that.
Yeah. So Mohammed, it's not. That's what a lot of people have this misconception that it is related. It is elevation from what is normal, but it's not. That's not what it is. Kuntavai had told the correct answer. Just Kuntavai, can you elaborate a bit?
Sir, it is compared to the best fit sphere, which we call, which is considered as the normogram for the for all keratographic findings. That is.
So you mean to say that the best fit sphere for all the patients in the world is the same?
I'm not sure about that, sir.
Yeah. So if that was the case, why is it called the best fit sphere? It would just be the sphere, the standard sphere against which things are measured. So no, that's not what it is. Okay, right. So I want to tell you a very important thing about tomography, and in general, I'm talking about Scheimpflug tomography, where the standard is the pentacam. Okay, OBSCAN is out. Pentacam is the the standard machine now. Okay, so a best fit sphere is actually a statistical calculation. Okay, now just imagine a curve is drawn. Okay, and if we were to draw a line, okay, let's say just across like a horizontal line, and if we were to draw the line in such a way that the net distance of every point from that line should be the same. That means, let's say we take points at let's say 1 centimeter intervals, and this line is total 10 centimeters long. Now let's say one point is 1 centimeter below the line, another point is 2 centimeters below the line, another point is 1 centimeter below the line. So now you have 1 centimeter below, 2 centimeters below, 1 centimeter below. So total is what? 4 centimeters below the line. Correspondingly, it's let's say above the line there are another 3 points, the summation of which, the addition of which comes to 4 centimeters above the line. So if the thing above the line and below the line is the same, that is the best fit line for a certain curve. Understood? Because that line is basically the average of the elevation or depression under or above that line for all the points on a line. But the cornea, it is a 3-dimensional surface, so we don't have a line. What we have is the sphere, a best fit sphere. So a pentacam measures all the points at a 8 millimeter diameter. of the cornea. So it takes the values of all of those points and it generates a sphere, like just a hypothetical imaginary sphere, such that the net elevation comes to 0. This is what a best fit sphere is. So for every single patient, it is different. And not only that, it is different for anterior and it is different for posterior. The anterior elevation has a different best fit sphere and the posterior elevation has a different best fit sphere. For every eye, it is a different one. So we are not measuring against some sort of normative data or some normal. We are only measuring against other points on the cornea. I hope this was clear.
Yes, sir. Yes, sir. It's clear now.
You kind of understood. I know it's a little difficult concept to grasp, but it's important because what we are basically looking for in keratoconus are patterns. So it's like your pattern deviation of Humphreys field analyzer. You
Yes,
are not
sir.
trying to compare against normal. What you're trying to compare against is the other parts of the cornea, because in keratoconus specifically, only one part of the cornea becomes ectatic. The whole cornea doesn't become ectatic. Okay. So it is important for us to compare how one part of the cornea is elevated as compared to the other parts of the cornea. And we need to do this separately for the posterior curvature and separately for the anterior curvature. Why? Why do we need to do it separately?
Because the anterior and posterior curvature are in terms of diopter of dioptric power, it is different, and the surface is not the same. So
yes,
there can be more posterior elevations also when compared to anterior and vice versa.
Exactly. Basically, the anterior curvature and posterior curvature are not the same. They are different shapes and they need different best fit spheres. Also, the progression of keratoconus is not the same for anterior and posterior. Usually, keratoconus begins in the posterior surface. Like the posterior elevation will always show changes first, and then the anterior elevation will show changes. Okay. Now, this is kind of out of the syllabus, but if anybody knows the answers, do you know the cutoff values for what is generally considered normal on a pentacam on elevation data? So if you are going to do a LASIK for any patient, you should know the cutoff values. If you ever do a LASIK with incorrect cutoff values and the patient goes into ectasia, you could get sued big time. Right. So we'll go there later, but I think Vrushali disconnected. Okay.
I think she'll get back. We can
she'll get back.
Continue
Okay.
further.
Right. So my next question is, let us assume that this is a case of keratoconus, although it's not, but let us assume that this was keratoconus. When would you do a C3R? One thing somebody already mentioned was progression, when you have documented progression. When would you not do a C3R, even if you have documented progression?
Sir, when there is significant corneal scarring.
Why does scarring preclude C3R?
Sir, one thing that I would contradict what I said is scarring will actually reduce the progression. It will flatten and kind of there is increased integrity. So if scarring is there, we usually the progression is also less. So
in keratoconus, why would scarring happen? What causes scarring in keratoconus?
Sir, one is in post-acute high drops, there can be scarring, sir, and because of basement membrane breaks, there can be scarring.
That is only acute high drops. So acute high drops, does it happen in mild, moderate, or advanced keratoconus?
Moderate cases.
No, man. Very advanced. Okay. So anyway, in acute high drops, you are looking at a very, very thin cornea. So is there any cutoff for thickness? How thick a cornea has to be for you to do corneal collagen cross-linking?
Sir, I've forgotten the value. It should be around 430 to 450. Yes.
Close. So after epithelial debridement, it should be 400. That is what was published originally. That those are the original guidelines. That publication was based on some animal studies and does not have complete validity. There are a lot of newer articles, and the newer methods do not follow this. But anyway, for exam sake, you should say that the cutoff is 400 microns after epithelial debridement. After the epithelium is gone, whatever is residual should be less than, should always be more than 400 if you want to do a C3R. Okay. Why should it be more than 400? What happens if you do C3R in a, say, 150 micron cornea?
Sir, UV light absorption will actually UV light is harmful for the nucleated cells. It will affect the endothelium, and there can be endothelial decomposition.
It's
So a
not the
minimal
UV
thickness.
light which is causing the decomposition. UV light anyway comes in through the sun and all. What causes the decomposition? You're right, you're on the right track, but what causes it? How
So
does C3R happen?
denaturation of proteins.
Yeah, but why?
Sir,
That's correct.
absorption of the peak of riboflavin that we
Yeah,
give
exactly.
is,
So how does cross-linking happen? Riboflavin has a chemical reaction in the presence of this light to release oxygen-free radicals, right? So these oxygen-free radicals cause damage. That is how they kill all the keratocytes. So if they kill all the keratocytes, they can also kill the endothelium. So that is why if you have a very thin cornea, the light can penetrate all the way across right till the endothelium, and then when the riboflavin releases its oxygen-free radicals, it might end up killing the endothelium also, and you will end up with corneal decompensation. That's why theoretically you're not supposed to do C3R below 400 residual thickness. Does anyone know what all types of C3R are there?
Sir, procedure wise, a standard
okay.
conventional type and accelerated C3R.
Right. So what are the differences between the two?
Sir, in conventional type, the energy and the duration is different, sir. For example, in conventional type, the total time is 30 minutes. However, the total energy stays to 5.4 joules, sir.
Yes, it's absolutely right. And
whereas in
what is the power?
3 milliwatts, sir.
Yes,
3
very good.
milliwatt per centimeter square.
Very good. That is conventional. Accelerated?
Yes, sir. Accelerated, we have different protocols, but it is based on the Bunsen-Ruskol of reciprocity, where the photochemical effect of the UV lights is proportional to the total energy, regardless of the irradiance or the time.
Correct. Very good. Very
and
good.
We use 9 milliwatt per centimeter square energy for 10 minutes.
Absolutely right. That is the most commonly used accelerated protocol that we're doing nowadays. So this is all with epithelium off. There are some ways of doing C3R with epithelium on also, called iontophoresis, where the riboflavin is pushed through an intact epithelium using electrical currents. But practically, I have never seen it. I don't know if it happens anywhere in India. But practically, we do epithelium off only over here. Okay. Then what if the cornea is thin? Like what all things have been described in C3R for thin corneas? Any idea?
Contact lens assisted
Good.
collagen cross-linking, sir, and hypotonic riboflavin.
Yeah. So the idea is if you keep a contact lens on top, it will absorb some of the UV light, and it'll act as if there's an extra layer of cornea on top. But practically it doesn't work. Then the next thing is like what you said, hypotonic. So hypotonic riboflavin, it causes swelling of the cornea. So because the cornea swells up, it becomes thicker, and then it's as if you're doing a thick cornea. But again, this is also highly unpredictable. The same hypotonic riboflavin in some corneas causes a lot of swelling, in some corneas does not cause a lot of swelling. Unless you have an intra-op pachymeter, it's very difficult to judge. And sometimes it leads to over treatment also, or sometimes under treatment. It's very unpredictable. I'll just tell you the latest thing that is going on right now. So Farhad Hafezi, if you have heard this name, he's a big name in corneal cross-linking. So Farhad Hafezi and his group, and including Narayan Netralaya also, they have come up with an online calculator based on a certain nomogram, where in thin corneas, instead of giving the full energy of 5.4 joules, lesser energy is given, and they have shown it to be quite safe in even thinner corneas. The only limitation is that because the cornea that you're treating is thinner, the overall number of collagen fibers are less. So you're obviously going to cross-link less number of fibers. So the total amount of strength which is given by the C3R will be less. So despite your treatment, it might still end up in progression. And also you're giving less energy. So that's another thing. But that's the latest thing, and that's what I'm also following, where I just follow the nomogram, and it seems to work. At least in the last 4 years, I have not had a single continued progression after C3R, even in thin corneas. Okay, now next. So I think contact lenses we can skip, right? You guys got a fair overview, but you should read about them. You should especially read about PROSE, P-R-O-S-E. I think the full form of PROSE is prosthetic rehabilitation of ocular surface ecosystem. That's the full form of PROSE. It was developed in Boston. Right, that is contact lenses. That is to improve the vision. What else can be done to improve the vision if not contact lenses? What if the patient is contact lens intolerant?
We can go ahead with intracorneal ring segments.
Yes, ICRS. That's one option. What else?
Sir, DAL.
No. I'm talking about eyes in which C3R has been done or can be done. ICRS is the correct answer. What else? Something like ICRS, which was invented by Dr. Susan Jacob in the south, in Tamil Nadu. Has anyone heard of something?
The case.
Yeah, CARES. Good. Who answered that? Priyadarshini.
Yes.
Explain CARES, please.
The corneal allogenic intrastromal ring segments, in which we take corneal stromal rings from the donor cornea and place it intrastromally in the keratoconus patient.
Correct. Good. So it acts exactly like an intax, whereas in intax we keep the ring is made up of a rigid material like PMMA. Yes. Whereas in CARES, instead of putting a rigid material like PMMA, which has a lot of risk of extrusion, necrosis of the cornea, the PMMA ring going inside the eye and causing all sorts of problems, etc. Instead of that, a strip of cornea is cut into the shape like an intax, and that is put into a stromal pocket. This pocket may be made manually, or better if we make this pocket using a femtosecond laser, which is easier and safer. So okay, CARES and intax. What else? What else can you do to improve vision? What if you diagnose the keratoconus very early? The patient's corneal thickness is 500, but it's keratoconus. You can do a C3R also, but the patient wants vision and will not wear contact lenses. What do you do? Priyadarshini? Laser, yeah. What all lasers can you use?
Sir, excimer PRK can be done.
Yeah, PRK can be done. So there are some papers which have shown that PRK along with C3R, that means simultaneous procedure, is better than sequential. That means doing a C3R first and a PRK later, or even doing a PRK first and a C3R later. So a PRK is basically a photorefractive keratectomy, in which something like a surface LASIK, but it depends on how much the refractive error is, depends on how advanced the keratoconus is, and you obviously have already an pre-existingly weak cornea. You don't want to weaken it further by ablating even more tissue. So this has to be taken with a pinch of salt, and it has to be done very carefully. Sometimes you may not want to correct the entire refractive error. You may just want to regularize the corneal surface and remove at least the higher order aberrations, so that the patient gets a better quality of vision with spectacles. So that is PRK with C3R. Okay. Then what else? DALK. Somebody mentioned DALK. What is the full form of DALK?
Deep anterior lamellar keratoplasty, sir.
Okay, so why that and why not PK, penetrating keratoplasty?
Sir, when comparing to PKP, the chances for endothelial rejection is close to nil in DALC, sir, as we are not touching the decimus or the endothelium.
Okay,
And
that's good. That's correct. The rejection is 1 point. What, any other points which because of which DALC is better than PK? Can you just explain what DALC is to the others?
in deep anterior lamellar keratoplasty, we remove only the anterior layers involving the epithelium bowmans and the decimus membrane of the recipient.
No, not desmus membrane.
Sir, stroma,
Stroma.
posterior and posterior stroma,
Yes.
leaving behind the decimus and endothelium. Whereas
And
in PKP,
wait. Leaving
Duas.
behind, yeah, duas,
Duas
desmus,
decimus
and
and endothelium. Whereas in PKP, there is a full thickness graft which is placed after removing the patients.
Good. So, complication wise, one thing you said is rejection. Rejection are obviously less because embryologically, endothelium, epithelium, and the stroma, they come from three embryologically different sources. So, they have different antigens. And if you remove if you replace the endothelium, the chances of rejection are much more. Endothelial rejection is the most common kind of rejection. So, DALC has very low rejection rates because you're not removing the endothelium, which is perfectly healthy in these patients. You're removing only the diseased anterior lamellae. Okay, rejection. Then what else? PK has lots of complications, which DALC does not. PK is an open sky surgery. So the moment you
Intraocular complications and more.
all the surgery, all the complications of open sky surgery are not there in DALC. In PK, you are just opening the cornea, so the pressure inside the anterior chamber becomes zero. So if there is vitreous pressure, it can just push out the nucleus. It can cause vitreous to come out. It can cause an expulsive choroidal hemorrhage, and so on and so forth. Whereas all of these things pretty much do not happen in a DALC because it's a closed chamber procedure. It's like the difference between an ECC and a phaco. Okay, good. So I think this was a good case and presented well, and I think many of you had studied and come, which I really appreciate. Very good. Do you have any questions? I think Mohammed has put a question here. Let me just see it. What is the importance? Okay, Fahad.
He has mentioned his name is Fahad. So,
okay. Yeah.
Please excuse us, Dr. Fahad.
Oh, sorry. Okay, Fahad. Right.
Yes, sir.
Dr. Fahad.
I want to ask, what is the importance of best fit sphere? Because this is a term which confused me a lot in the keratoconus. Previously, I used to thought it is the best of the sphere. If we give it to the patient, then he'll have the best VA. But my concept was wrong. But so I want to ask, what is the importance of best fit sphere?
You're talking about topography, right?
Yes, sir. Topography.
Okay. See, we need to measure. Okay. In keratoconus specifically, we need to measure elevation. That means we need to we have to define a surface. Okay. Now there are mathematical ways of defining surfaces. For example, you might have seen Zernike's polynomials. Those are methods of describing surfaces. But normal human beings who do not understand maths, which is doctors, cannot understand mathematical equations which define the shape of surfaces. Okay.
Yes.
So we need something simpler which doctors can understand. So what will doctors understand? We know that ideally what do we want? We want the cornea to be a sphere. If the cornea was a sphere, that would be perfect. That would mean ki haan, sab kuch theek hai, it's all good. Okay.
Yeah.
So what we are trying to do with a best fit sphere is we are comparing the actual corneal surface with what was theoretically an ideal corneal surface. It's like wavefront analysis. Okay. But in a different way. So what we are doing is we are basically comparing what the shape is to what we would want the shape to be, which is a sphere. Now, we can't take any random radius sphere. Let's say the average radius of a cornea is say suppose 7 centimeters. What I am just taking any number. Okay, let's say 7 centimeters. You cannot
Yes,
make a sphere of 20 centimeters and try to fit it. It will not even be close. Okay, so you want a sphere which is very similar to the actual surface, but obviously it cannot be exactly the same as the actual surface because the actual surface is not a sphere. So you are taking a sphere which most closely matches the actual surface which is being measured, that is the corneal surface, let's say the anterior surface. And then you are taking each point on the cornea and measuring how far away that point is from this ideal sphere. I hope this makes the point clear.
Yes, sir.
So this just
Thank you,
helps
sir.
us. This just helps us mere mortals who can only understand basic, basic numbers and basic diagrams, and we don't understand mathematics at all. So it just gives us a guideline. It just compares to a normal sphere, and it's not always best fit sphere. Okay. In the pentacam, there are various options. You can even take a toric ellipsoid. You can take an ellipsoid. Basically, there are various best fit shapes. Like for example, a patient with, let's say a patient has astigmatism. Okay. Let's say a patient has regular astigmatism with the rule. So what do you mean by with the rule astigmatism? The vertical.
Deepest at 90 degree.
Okay. Yes, that's correct. So if you were to take the vertical meridian, the cornea would be steeper, vertical to horizontal, whereas top to bottom would be steeper,
Yes,
whereas left to right, nasal to temporal, that meridian, the
against the
horizontal
rule.
meridian would be
Against the
flatter.
rule.
Yeah. No. In with the rule astigmatism,
Yes, sir. Yes, sorry, sir. Yes.
vertical is steeper and
Vertical
horizontal
is
is
steeper, then
flatter.
horizontal is flatter. Yes.
Now, just imagine if we were to put a best fit sphere for this surface. Okay. Now what will happen is the best fit sphere is trying to fit in between these two meridians. Okay.
Yes.
So for this best fit sphere, what would happen that let's say a point at 12 o'clock and a point at 6 o'clock. Okay. That means along the vertical axis, right? Along the vertical meridian, sorry, not axis, along the vertical meridian, these points would be behind the best fit sphere because the vertical curvature of the cornea is more. So they would be behind, they would be posterior to the best fit sphere. But the horizontal curvature of this cornea is flat. It's relatively less curved. Okay. So this flat one would, let's say the 3 o'clock and the 9 o'clock points, the ones on the horizontal axis, they would be anterior to the best fit sphere.
Anterior to the best side.
I hope this is clear. Now, if we were to look at this on that map, the topography map, there is a color scheme. So the color scheme shows that points which are anterior to the best fit sphere are shown as red, and those which are posterior to the best fit sphere are shown in blue. Blue matlab, I mean to say cool colors, and red, by red I mean red warm colors. Okay. So what we would find is that superiorly and inferiorly everything would appear blue or green. Okay. Whereas temporally and nasally everything would appear
red.
Red.
Sir, but red means isn't the cornea is steeper from there if it is showing the warm colors?
No.
So
when we are talking about elevation, we are not talking about steepness at all. When you say steep, you are talking about keratometry value. You are talking about curvature. When we are talking about elevation, we are only talking about how far it is from the best fit sphere. That's all.
Okay, right.
Okay. So in this case, what would you find the curvature to be? This is a regular cornea, right? There is no keratoconus anywhere. So if you were to look at the keratometry map of this patient, you will find just regular astigmatism. You will find that the curvature at every point is like whatever, very similar to each other and exactly corresponding with the patient's keratometric data. Also, one question, like everybody keeps talking about K1, K2. K1, K2 is a very vague descriptor. Okay. Can someone tell me what SIM-K means? Everybody uses SIM-K, but I'm pretty sure not many people know what it really means. Can you describe what SIM-K means? What is SIM? You've heard of this, SIM?
Anyone else can take up?
Okay, Fahad, any idea what SIM-K means? What does SIM stand for?
Sir, I have no idea, but it means simulated, I think. But
Yeah,
I
that is
don't.
correct. So it is simulated. So anyway, I'll
That's
just
the
tell
tuka,
you.
sir.
That's
I don't
correct.
know.
That is the full form of SIM. So just for your guys' information, keratometry was originally measured using a keratometer. Okay, and this keratometer was the Bosch and Lomb keratometer. So this had a very standardized defined Meyer. Like the Meyer was, I believe, at 3 millimeters. The 3 millimeters zone was where the Meyer was. Now the cornea has an aspheric surface. That means that the center is usually steeper, and as you go towards the periphery, it becomes flatter and flatter. So for a normal person, if the Meyer of the keratometer was measuring at 3 millimeters, it would give a certain value, let's say 42 and 43. But if for the same patient, if we made a keratometer with a bigger Meyer, with say a 4 millimeter Meyer, then it would give different readings. It would give flatter readings, because as you go from the center to the periphery, the cornea becomes flat. So what is the real keratometry of this patient? Is it 42, 43, or is it 41 and 42? Okay, so there is no real. Okay, that's the point. There is no real. These are just different keratometry values at different diameters from the center. Okay, so over the years, what is measured by the old Bosch and Lomb keratometer is considered the standard, and most of our measurements, most of our formulae, like for example the Sanders Retsalf Kraft formula, the SRK formula, and so on and so forth, all of these formulae, all the mainly the lens calculation formulae, they were based on Bosch and Lomb keratometry values. Their standardized constants, etc., are based on those values. Therefore, if we use a new keratometer which has a different sized Meyer, you cannot use those values because you will get the wrong value of the lens. So what we have to do is give us addition or a subtraction, which will make it as if it is a 3 millimeter Meyer. That is a Meyer which was measured by Bosch and Lomb. So we are simulating the Bosch and Lomb keratometer using our actual values. That is what SIM-K is. I hope you understood. So that it fits into all our formulae. So if you are going to use a topographer to do your lens calculation, you should be using SIM-K values, not K1, K2 values, not all the, there are lots of values. If you see a topography, they'll say K1, K2 at 2 millimeters, K1, K2 at 4 millimeters, K1, K2 at 6 millimeters, because these are all different Meyers at which the keratometry can be measured. But what will you put in your lens calculation formula? You will put SIM-K values, because they are the ones which are simulating the old Bosch and Lomb keratometer on which all the formulae are based.
Sir, can I ask a doubt?
Yeah.
So the SIM-K is basically which involves the keratometry readings of the central 3 mm of the cornea, sir.
Yeah.
In all cases. Oh.
Yes, it is a simulated value. It's not actually measured.
Okay, sir.
Yeah, it may be actually measured also. It depends,
Yes.
but it basically corresponds to the old Bosch and Lomb keratometer.
Oh.
And just check whether it's 3 millimeters. Okay, I don't remember whatever the size of that Meyer is.
Okay.
Yeah. Any other questions?
I think topography will take another
long.
class in itself.
Yeah, that's too long. Correct.
But I think whatever points you have explained, at least they have been quite explanatory for me as well. So, does anyone have any doubt? Or everyone is already sleeping?
Sir, I have a doubt, sir.
Yeah.
Not particularly regarding keratoconus, but regarding an post-classic ectasia, like when should we suspect a post-classic ectasia rather than keratoconus progression, sir? Like with patients having unilateral refractive error who've done LASIK or any refractive surgery previously, and now they're coming for the OP, and we find a refractive error in both eyes. How to differentiate it, sir? Like
So
clinically?
Usually, first of all, clinically you cannot. You do need a topography. Okay. Clinically, it's very difficult to judge. Also, preferably you need serial topography, as in you need to have at least 2 topographies to compare.
Okay.
Okay, comparison is ideal, but in some cases you need not compare. As in, if you have done a LASIK, you know that the patient was 6'6" post-op, and then later on you see a pattern which is exactly consistent with an ectasia. Okay, it should not be consistent with regression. Many times regression gets confused with ectasia, but ectasia and regression have different keratometric patterns. Okay, I mean, sorry, topographic patterns. So if you can, if the pattern is self-explanatory and that it is ectasia, then you will go for a C3R right away. But otherwise, you will wait a very short while, like maybe do a repeat topography within 3 months or so, and see if there is any progression. And if there is progression, go straight for a C3R. But yeah, this is a bit complicated. Like we need to see many examples, and then I can show you which is which and what is what. Topography is basically like I think Fahad is also asking for a class on topography. Yes, we can do it. It's a very extensive subject. I would require people to read the entire book before coming though, because I can't because like this best fit sphere, it's so difficult to explain. It's a lot easier if you've already read it. Okay. Yeah.
Thank you.
Okay. Okay, Dr. Anuj, it was wonderful. I think we had a really good time, and everybody had read and come, which is good.
Absolutely. I think hats off to you and for taking the pains. And this is diagnosed as keratoconus by me only. So please excuse Vrushali. So, but it was really nice for you to spare time, and I think everyone has really helped